Gaddis and I started, a few months ago. We've been doing this for in the teens of weeks now, every week at Thursday at 7 p.m. It's been really, really exciting. Different speakers, different topics in within the medical education realm. And the most exciting part, Dr. Gaddis and I were talking about, was really how it's kind of become a community. Outside of just Thursday nights at 7 p.m., we've been interacting with a lot of the people who've been joining us, and we love to hear it. So I was texting with Dr. Patel not too long ago, a couple of days ago. We really love it. So feel free to reach out. We're on Instagram, we're on LinkedIn, we're on Twitter, we're on all the social medias.
Yep.
Yeah, we'd love to hear from you guys, whether it's just a chat, ask questions, reach out to the speakers, or even for feedback. We love it. Without further ado, Dr. Gaddis will introduce our esteemed guest for the evening.
Yeah, thanks, Dr. Omar. If you guys forget, somewhere on your screen there is a little heart. Feel free to click on that heart. That gives our forum a like and brings us more to the front page so that we can get more traffic. But anyways, so I have the pleasure of introducing our guest today, Dr. Emeka Ajufo, formerly known as Dr. Blade, who was an inspiration by Wesley Snipes. Just found that out a little while ago. But he's going to talk to us today about strategies on enhancing the recovery of tendon ruptures. And this goes in line with the theme this past month on orthobiologics. A little bit about Dr. Ajufo. So he is born to Nigerian parents and raised in Florida. Passionate about sports, he grew up playing soccer and football, and a string of injuries during college exposed him to the world of physiatry and regenerative therapies. He has been a passionate advocate of regenerative therapy and its rehabilitative properties ever since. He got his undergraduate degree at the University of Florida. Go Gators, baby. That's my alum. And he got his medical degree at the American University of the Caribbean. He is also the creator of Blade Fitness, which I just found out is a hybrid web-based and personal-based health and fitness platform led by Dr. Blade himself. It's a health coaching platform to provide patients and clients with the tools to empower themselves to make healthier decisions and reverse chronic diseases. So without further ado, everybody give it up for Dr. Blade. Emeka, the stage is yours, my friend.
All right, thank you for that amazing introduction. All right, so hopefully you guys are excited for today's presentation. A lot of this kind of comes from my own personal journey, but hopefully it's something that you guys leave with, some tools that you guys can use whenever you get injured, or if you're a clinician, that you can use on your patients. So let's begin. So today's agenda. The first thing that we're going to talk about is the most common cause of tendon injuries. It's a very simplified way to look at it. Also, we're going to talk about the differences between a healthy versus a compromised tendon. We're going to talk about the current standard of care when it comes to rehab in general. And then I'm going to kind of go into my own personal journey. And then I'm going to talk about 3 different components that have enhanced my healing that has been shown in the literature to enhance healing in general, and how we can implement all these things. And that's going to include growth factors with bone marrow concentrate. That's going to be neuromuscular electric stimulation. And it's also going to include BFR, which stands for blood flow restriction. And I'll kind of talk about how all of those different components work. So let's begin. So the simplest way to think about it is tissue injuries, tendon injuries. Most injuries occur whenever a tissue experiences an applied force that is greater than whatever that tissue's tolerance is. So if you look at it as like a mathematical formula, it's essentially going to be when the applied force is greater than the tissue tolerance. So you notice that children are able to get in all these little Gumby positions and be very pliable. And as we get older, we become closer to like a Tin Man unless we do something to stop that. And that's because our tissue tolerance over time as we age progressively gets worse unless we're doing things to counteract that, working on our mobility, working on making sure that if we do have injuries, we're rehabbing appropriately and we're staying very flexible and pliable. So this little diagram kind of just shows different things over time. So you see after, like, say you had one rough shift at work or you're playing sports, your tissue tolerance throughout the day might decrease, but you rest, it's going to go back up. Then say you've had a week of stress, your tissue tolerance goes down a little bit more, and then you rest and it improves. But over a long career, doing something that's putting your tissues at a vulnerable position, you're going to end up lowering your tissue tolerance. And that could lead to injury whenever the stimulus is high enough. So this is a great way to look at the difference between healthy and compromised tendons. It was actually my knee doctor, Dr. Pappas at Regenerative in Tampa, that kind of said this. He's like, a healthy tendon looks like a new broom, and you can see it has like healthy parallel fibular pattern, and then a compromised tendon essentially looks like an old broom. And it has disorganized fibers, it's thickened, it's less elastic. And that, when he was talking about the compromised tendon, he was talking about my tendons. Because I've had a string of injuries ever since 2014. I've had patellar tendon ruptures. I grew up as a kid having a condition called Osgood-Schlatter's disease, which is essentially like having patellar tendonitis as a teenager. And so throughout most of my adult age and even my youth, I've had knee pain, especially my patellar tendon. And eventually, just because of what the different ways that my body had to find in order to deal with all of that stress and all that pain and all that inflammation over the years, it kind of compromised my tendons, leading to the rupture that we're going to talk about in the future. So when you look at, actually, I got a quick question for you. Dr. Gaddis, is there a way for me to look up? I can't see like the top of my presentation.
Oh, yeah. So if you take your mouse, and if you click onto the screen and drag your mouse up, it should take your attention up.
Perfect. Yeah. All right. So now we're going to talk about the ultrasound findings, so that way we can tell the difference between a normal tendon and a compromised tendon. So what you'll notice in tendons that have tendinopathy or chronic tendonitis, you'll notice that the cross-sectional area is going to increase. One thing, and this is the cross-sectional area, it's essentially the thing in yellow that looks like a circle. That's the cross-sectional area of the tendon. And I'm going to show you essentially the positioning that we're using. And another thing, someone else clicking on this? I think someone's touching this. All right, be careful not to touch the screen, because anybody can touch the screen and they'll flip to a different slide. All right, so another thing that we're going to notice is there's going to be increased neovascularization. A normal, healthy tendon has no vascularization. You're not going to see microvessels, and that is one problem with tendons. They have a poor blood supply. So if you ever put an ultrasound on top of a tendon and you're noticing that, and you put on Doppler mode and you see like all of these little, you're going to essentially see the Doppler go off, and that's going to tell you that there's a blood supply there, and that's a sign that this tendon is not healthy. And then if you look at this slide, it shows you when you look at a normal tendon structure, it's nice, it's fibular, everything is parallel, and it's pretty thin. But as the tendon has gotten stressed over time and it becomes compromised, you can see like it's much thicker. And this position that we're looking at is a longitudinal position right here on top of the knee. So I don't know if you guys can see it, but essentially here's the probe, and it's just in the center of that tendon. This is the transverse position, and this is the longitudinal position. So this is actually this position, and then this position is that position. And in the transverse position, you're going to be able to see the cross-sectional area. And as you can see, this is the healthy tendon, and this is the other one. The compromised tendon, as you can see, is getting bigger. So the tendons become thicker. It's not as compact. And that's a sign that things need to be fixed. All right. And like I spoke about earlier, you're not supposed to see that because tendons are avascular, you're not supposed to have a Doppler turn on and see all of this red and blue, which is a sign that there is neovascularization. So this essentially, there's different grades of neovascularization. Grade 0 is there's no visible vessels, and then essentially grade 4 is you're seeing up to 30% of the area has some vascularization. And then there's like 1 and 2 in the between. It's not super important. But the biggest thing is just noticing that, hey, if you're seeing neovascularization, that's a pretty good sign that this tendon is trying to heal, but it's not doing a very good job. So now it kind of brings me to what the current standard of care is. So we've all been taught this since the beginning of time. You get injured, rice, right? So rice essentially means rest, ice, compression, and elevation. And there are some slight derivations of it that you might have heard. And then when you've done that for long enough time, if you're not healing, then typically you might kind of go down the route of having surgery. And after any type of surgery, there's going to be some excess trauma in order for them to get to the site that they're trying to get to. And then you're going to have a long period of immobilization. And then during that time of immobilization, you're going to also deal with significant atrophy and weakness. And that's, if you've ever gone through this experience, like if you ever had a serious injury, you no longer would take movement for granted because you see how hard it is just for you to get back to a normal state of function whenever any injury happens because of these processes that are occurring, the atrophy and the weakness. So what I like to call is rehab 2.0. And because of my specialty working as a physical medicine rehab physician, and also the fact that I like to injure myself throughout my life, I've learned kind of a lot of tricks and trades from different people that are really great at helping athletes get back to higher level of function. And these are the things that have kind of shaped what I did during this time around during my most recent injury. So number one thing is the electric or electronic muscle stimulation. And I'll explain these down the road. And then the number two thing is the blood flow restriction. And then number three is the orthobiologics. So now I'm going to kind of talk about each of these. So first, let's kind of go through my journey. This is my journey of 2022. It's been an interesting year. I was on a cruise ship on May 26th with my girlfriend, who's in the stage, Melissa, and she was playing volleyball, and I decided I wanted to play too. So I hopped on there to play some volleyball, and while I was trying to spike the ball, I ended up tearing my patellar tendon on a cruise ship, which is not a great place to injure yourself. They do not have the medical care necessary to take care of this type of stuff. So I injured myself. They take me to the infirmary. They give me an x-ray, told me some interesting information that said, oh, the x-ray looks great. Obviously, I knew what I did to myself, so I was like, this person's incompetent. I'll figure this out myself. So then I get off the ship. I'm sent to University of Miami, an ambulance, and then they kind of start my process. And then eventually on June 6th, which happened to be my mother's birthday, and 6 days before my birthday, I get my surgery. So at that time, my patellar tendon was reattached, and it's a very painful procedure. It's rough to go through, so hopefully none of y'all have had to go through that or have to ever go through that. So June 9th, that's when I really started my home therapy. The pain from the surgery had kind of subsided enough for me to start incorporating some exercises. The first step in most knee injuries, especially when you have surgery, is being able to lift your leg, do it a straight leg raise against gravity. You can't do that, you can't walk, because it's essentially mimicking the pressure whenever you would take a step. So if your leg collapses whenever you're trying to do that, you're not going to be able to walk. So I knew that that was the first thing I needed to do. However, I couldn't do it by myself. So what I did was I used an electric muscle stimulator to flex my quad stronger than my brain would allow me to flex my quad. And then I would do the exercises. And I also added the BFR restriction as well and I'll tell you why I did that. But right now, I'll just kind of talk about the electric muscle stimulator. So what that did was it allowed my brain to say, okay, this is okay for you to be in this position, and allowed me to get to the point where I could do a straight leg raise in like 4 days. This is something you normally can't do for almost 2 to 3 weeks. And then June 21st, I saw my knee doctor right there, Dr. Pappas, and what we did was we put bone marrow aspirate into my knee. We took it from my hip, and then we put it into my knee. And then June 24th, I started working out at the Movement Lab, which is a physical therapy center that trains a lot of professional athletes and NBA players and stuff. So that environment was great because I saw people that were super high functioning that kind of inspired me to make sure that I got back to high functioning levels as well. All right.
Dr. Blade, what's BFR?
There's blood flow restriction.
Blood flow.
So essentially and I have it in the slide where I kind of break down what that is, but essentially it's like it occludes the blood that's entering into that area. So you'll put it essentially at your hip or like at the top of your bicep, and you'll like train your legs. And what that does is it lets blood out, so that way you don't lose a limb, but it kind of minimizes the blood that's coming. It's actually the other way around. It minimizes the blood that's going out, so like from your veins, but it allows your arteries to still pump the blood through. And what that does is it allows you to get the same type of metabolic stimulation as having an intense workout without having to use as much load. All right. So I have a slide that kind of talks about that. Okay. So when it comes to the biggest thing, like I mentioned earlier, is you want to minimize atrophy, because once it takes you years to build the muscles that you have right now, and it takes days to lose all of it. And you saw that there was one study that showed that in as little as 3 days following immobilization, you can start to see some significant atrophy. And the protocol that I was put under by my orthopedic surgeon, that I clearly didn't listen to, but it told me to be in a straight leg for 6 weeks. So I would have my quad immobilized for 6 weeks. And for me, I knew what that would do to me. I knew how much atrophy I would go through, and that would probably take me years to deal with. So that's why I had to do all these other things to prevent the atrophy. And luckily, I was able to, because now my legs are the same size. One's not like significantly smaller than the other one, because I knew that this was something that I had to fight against. And when it comes to the muscles that are more prone to having this atrophy, it's going to be anti-gravity muscles. So these are muscles that are important to hold us upright. So like you'll notice that, say you had surgery on your knee, you're not going to lose your hamstring because your hamstring is not an anti-gravity muscle, but you will lose your quad a lot quicker. All right. And also one thing to consider is the position that the muscle is in. So if the muscle is in a shortened position, it's more likely to be the atrophy is more likely to be exacerbated. So for instance, if your leg is straight, your quad is in a shortened position. If your leg is bent, if your knee is bent, your quad is in a lengthened position. So that's another thing to consider. You want to protect, obviously, the surgical site, but you also want to make sure that you're not like doing everything possible to speed up the amount of atrophy that you're going to get.
Interesting. I didn't know that about like the shortened length. I guess that makes sense in terms of if you have an extended muscle, then the resting muscle tone of that well, I guess the resting motor tone of that muscle would be increased, thereby keeping it from atrophying as much, I guess.
Yeah, I think that's a very reasonable explanation for why that occurs. But also now you're dealing with the fact that the muscle gets used to that position, and now you're going to be extra tight, like trying to bend. Like if your quad's been in a short position for 6 weeks, good luck trying to get back to 90 degrees. It's going to take forever.
Yeah.
Okay. All right, so we'll kind of talk about all these different modalities that I was talking about. So the first thing is the electric muscle stimulator. These are wireless compacts. They don't pay me, so I'm not like promoting them, but it's a good tool. I recommend it. All right. So those are right there. And this is oftentimes it's confused for a TENS machine, which is transcutaneous electric nerve stimulation, which essentially is just kind of distracting your nervous system from your pain signal. What an electrical muscle stimulator is doing is it uses a different frequency, and it's actually going to target your motor nerves similarly to the way that your brain would in order to get it to contract. And the difference between your brain and this machine is that consciously, humans can only contract the muscles to maybe 60 or 70% of the capacity. Machines like these can get you to 100. So like they could you don't want to overdo it. You'll get like rhabdo. You'll have the worst soreness of your life. But that's how strong the signal is that it can come from these types of machines. So now I'll talk about what blood flow restriction is. So this is essentially using a high-tech tourniquet. So you can see it right here. It's a little different. This is the one I use at therapy, and the other one was the one I have in my house. So it's essentially going to occlude your blood flow leaving your limb, and this is going to allow us to achieve much of the same benefits you get from the max effort training while only working at maybe 20% of the same resistance. And this is going to help you progress in your strength training when you're trying to deal with injuries or even trying to increase muscle mass without putting so much stress on your tendons and your joints. So there's different protocols that have been seen in the literature for how to do the BFR training. But what they've seen is that if you're using like a low load BFR training, it's going to have similar morphological and mechanical adaptations compared with some high load resistance training. And if there's a study that they did where essentially they had two different groups. One group was training at 85% of the 1 rep max for 4 weeks. And then the other group, the BFR group, they started at 20% 1 rep max, and they eventually got up to 35% 1 rep max. And at the end of the study, using the same exercise and training protocols, the only difference was one had BFR, the other one didn't. They noticed that they had the same changes in muscle size and strength, along with tendon thickness and stiffness. So that shows that even without having to use such a ridiculous amount of load that your tendons or joints or whatever can't support, you can still end up having a significant amount of progress. And that's why BFR is so crucial for someone that's going through rehab. And then here's one protocol that I saw in the literature. And it's kind of far. I can't even read it from me. All right. So you can see, like, typically whenever you're doing BFR training, essentially the sets are going to be 30 reps, then 30 reps for the first set, and then you're going to do 15 reps for 3 consecutive sets after that. And that's what you can see in all of these different things. And then in terms of the occlusion pressure, you typically want to get to about 80%. And here's the thing. Anyone go on Amazon and buy some BFR cuffs, they're not all built the same, right? The two that I've showed you are electronic, and they're very good at dialing in the exact amount of pressure you're using, because if you just go get a tourniquet, like one that's like, they have these different ones that are like made of fabric, and you just tie it to your hip or your whatever joint, you can end up hurting yourself because you might be putting too much pressure, or you're just not getting an effective response because you're not doing enough pressure. So you'll notice in the protocols, they always tell you the occlusion pressure, and normally it's supposed to start at about 70 to 80%. All right, so now we'll talk about the healing properties of mesenchymal stem cells. And mesenchymal stem cells are the stem cells that you're going to find in the bone marrow. And then this can be a whole lecture in itself, so this is like a very simplified way to explain what's kind of going on and the power of bone marrow. So we don't fully know exactly how bone marrow aspirate and everything works, but a lot of people have postulated that mesenchymal stem cells have chemical mediators and cytokines that are going to communicate to the injured tissue and can control a bunch of different things such as cell proliferation, angiogenesis, which is the sprouting of new blood vessels, and it's also going to help mediate the inflammatory process, which is going to be required for repair. So you can imagine all of these things are very, very important for healing. And I mentioned earlier, tendons have a terrible blood supply. And where do we get these things from? Well, we get mesenchymal stem cells from bone marrow, but some of these things are kind of floating around in your blood anyway, but they're at such a small concentration, and even if they were at a high concentration, they're never getting to your tendons. So that's why we have to have orthobiologics and kind of take it from one spot and put it into another spot, because there's just not really good blood supply in most of these tendons. So that was the simplified version. But as you can see here, this is the super complicated version that kind of shows you all of the different pathways and things that are occurring. So one aspect of it is you see the mesenchymal stem cells are here. They have growth factors, which can lead to angiogenesis. They have growth factors which can stimulate the fibroblasts and help with the extracellular matrix. There's the component of these cells are multipotent, so they can also differentiate into the cells that they need to be in order to like replace cells that are damaged. Not sure why this thing's bouncing around. Someone clicking on screen? All right. All right, so there's a lot of things that these cells can do, which makes them such a powerful thing. And because I was aware of this, and because of the field that I'm kind of in, I was like, okay, this is something that I want to make sure that I do, especially during the early stages of my healing process when there's nothing but like a ton of inflammation happening. And I wanted to kind of reduce the inflammation and also try to get my body healing appropriately instead of just healing with tons of scar tissue like it did in the past. All right. So in terms of the research, one of the issues that I had and that we kind of have in this field is a lot of people that aren't in the space will always say, but what about the research? Is there any research? Like my orthopedic surgeon is literally the head of sports medicine for University of Miami. And he said there's not much research when it comes to this stuff. What that told me was he's just not staying up to date on it. There's tons of research when it comes to mesenchymal stem cells and what they're capable of. And a lot of this actually started from research into animals such as horses that were, you know how much people spend on horses, like these $1 million horses that they would use mesenchymal stem cells to help them improve from an injury. So you can see this one study, they said that implantation of bone marrow derived mesenchymal stem cells demonstrates improved outcome in horses with overstrain injuries of the superficial digital flexor tendon. So that was kind of where a lot of people kind of started extrapolating this into humans. They saw what was happening in horses and big animals, and then it started coming to humans. Obviously, there's a process to all this stuff. A lot of times we start in like rats and mice and stuff, and there are tons of studies on rats and mice and ability for mesenchymal stem cells to help with tendon regrowth. But then there's another study. This is in humans, where there was regeneration of meniscus cartilage in a knee that was implanted with mesenchymal stem cells. I'm sure many of us were told since we were born that, hey, you cannot regenerate cartilage. Well, apparently there are some cases where this is occurring with the right stimulation and the right concentration of these orthobiologics. And then there's another study where it talks about mesenchymal stem cells accelerate early remodeling of tendon, bone healing, and this is one of the studies that I read at the time. I was like, okay, I need to probably do this if this is going to help me during the early stages of my healing process. And then this is another study that talks about mesenchymal stem cells derived from exosomes, promoting tendon regeneration by facilitating the proliferation and migration of endogenous tendons, stem cells, and progenitor cells. So there's lots of wonderful and amazing research. This is still in its infancy, but it's very powerful research that's out there. So I recommend anyone that's interested in orthobiologics and regenerative therapy, just, go on the internet, go into these journals and just take a deep dive, and you'll be surprised at what you find. So in terms of how the bone marrow aspirate concentration process goes, essentially what we want to do is we're going to go into the core of your bone where you're going to find a soft spongy-like substance, and it's a lot of blood in there too. And this is where we're going to collect it. So typically we'll go into the anterior or posterior side of the hip. Most of the time it's posterior side of the hip. And that's where we'll get the bone marrow from, because they found that that's probably the best place to get the yield, the highest yield of the mesenchymal stem cells that we're looking for. And then essentially after you do that, we're going to concentrate these cells inside of a centrifuge, and then we use different products in order to get the concentrations to the levels that we want to, and then we re-inject them into the patient. And in terms of what has been seen, here are some before and afters that I'm giving credit to Regenix because there's all their stuff, and just to see how powerful these things are. So on the left-hand side, I'm not sure how well you guys can see it, but these are all going to be ACL tears, right? So an ACL is supposed to look like this, like this strip right here. But over here, you can see there's like pretty much no ACL. It's just all frayed, right? And then within, I think this was 28 weeks, just with an injection of orthobiologics, the ACL was completely healed. And the benefit of this type of way of treating an ACL is you don't have to go through all of the different parts of the knee in order to get there and damage excess tissue. That's going to also lead to more scar tissue. And then you look down here, this is the same thing. It was a torn ACL, it's frayed, and then you can see in the after shot, perfectly fine. And the same thing down here. And then when you look at the meniscus, this is a meniscus that had, let's see. All right, so you can see this meniscus is very frayed, and it's probably causing a lot of irritation every step this person takes. And then it's more uniform. It still doesn't look completely perfect, but in the aftershot, you can see it's significantly improved from what was going on over here. And this is kind of a similar case where you have a frayed meniscus, and then it's almost looking perfectly like it's supposed to look over here. So a meniscus, essentially, whenever you look at it from this position, is going to look like a triangle. You can kind of see triangles on both sides because the meniscus is essentially shaped like a donut with a slope, and the thickest part of the donut is on the outside, and the thinnest part of the donut's on the inside. Thanks for the claps in the back. And this is just the extra bonus. This is some cool stuff that I saw when I was working with Regenix. And this is the utilization of using something that's called MFAT, or it's micro-fragmented adipose tissue. It's essentially like you do a small little bit of lipo, and you're going to transplant fat from this person's gluteal region, and you're going to implant it in an area of tear. And this was a full thickness supraspinatus tear. Well, this is actually partial thickness supraspinatus tear. And they implanted the fat into that area, and then they also implanted some platelet-rich plasma. And then you can see at 28 weeks, the tissue healing has occurred. And a lot of times you'll notice if you work in this field that so many people have all these tears in their shoulder and nothing ever happens. They're like, sometimes they're not bad enough to have surgery, and the person's just in chronic pain for like the rest of their life, and they end up going through a bunch of phases of tons of steroids. But this is actually something that's going to end up giving them some relief and hopefully also improving their function depending on how bad it is. Oh, missing a slide. What happened to my slide? Can y'all see my slide, or did it disappear?
No, we can see it. It's just someone is toggling through it. If you guys wouldn't mind just not clicking on the slides so that Dr. Blade can go at his own pace.
All right. Well, I mean, I'm pretty much at the end anyway. There's supposed to be like an end slide that I can't see.
Okay, I see
right,
faster healing. There's a picture of you with orange sticks.
Yeah, that's what it's supposed to. I can't see anything. It's just a white screen for me.
Oh, I see.
Yeah, I don't know why.
How about?
But yeah, that's the last slide.
Okay.
Again, I don't know why.
Let's try.
At least I got to the end of the thing before that happened.
How about now?
Take a screenshot and see.
Oops, I'm duplicating it by accident. Oh, goodness. Sorry, let me just fix that. I got it, James. I got it. All right.
Well, it's the end of the slide, so we could talk. We can, if there's any questions.
Yeah. Actually,
I
had some questions. So I wanted to ask you, you were mentioning the blood flow restriction, and that's pretty interesting. I didn't really realize how therapeutic it was. I honestly thought, because I've seen it at the gym, I work out at Crunch, which is like your stereotypical bro gym. And I would see people with like these, elastic bands around their arms. And I was like, I just thought they were conceited, like trying to get their blood vessels to show. I had no clue that it was actually fostering like muscle hypertrophy. Now, you mentioned it in the capacity of like rehab. Would you recommend it for someone who's using it just to exercise and to get strong or gain mass or what have you?
So I don't think it's necessary for most people, but I could see where it could come into play. A lot of people that exercise a lot end up hurting themselves at some point, and you do get to a point where you're so strong that your muscles are so strong, but your tendons aren't. Tendons can't keep up. So this is where like something like BFR could kind of come into play, where you're like, okay, I need to try to bring up this lagging body part, but I don't want to like tear my biceps. So why don't I do this instead?
I see.
Right?
Yeah.
Because I can curl 70s or 80s, or I could just, curl 25s and use BFR.
Right. So the thought is that
speak
you
for yourself
minimize
about the. Go ahead, Mo. Sorry.
No, I was just saying. So the reasoning is that you're ultimately just trying to decrease the load while still achieving the same level of outcome in the end for your muscles.
Yes, you can achieve similar levels of hypertrophy without putting other parts like your tendons and ligaments at as much.
Gotcha.
Do you ever, for your clients, do you ever identify injuries and recommend them to get orthobiologic therapies?
Yeah, I had a lady that, she had self-diagnosed sciatica, but I told her to go to like Regenix. I saw her X-ray, her spine didn't look great. So like I definitely recommend it whenever it's applicable. Before I work with anybody, I have to know their injury history, which makes me a little bit different than a normal trainer, because or normal, online personal trainer versus a physical therapist. So like I make sure I do like a full screening of their injury history, and I also do like do lab work to see what their metabolic health and hormones look like before I start just telling them what to do.
That's great, man. Honestly, because like I wonder about that sometimes when you get these personal trainers who went to like a 6-week course and they're just steroids raging through their veins, and then they have this like 60-year-old lady as a client. They have her doing squats. I don't think they understand the full spectrum of disease out there. So for you to have a medical background, it just makes you stand out from the rest. That's amazing. Do you have room for a shameless plug for your fitness program?
Yeah, I have tons of room for that. So,
yeah, absolutely.
So, like I talked with Dr. Gaddis earlier. I am a health coach. So the difference between my health coaching and a typical health coach is obviously my medical background. My goal is to help empower people with the tools and the resources to help them be happy, healthy, live a long life. And the way that I do that is by providing people with essentially accountability and education, so that way they know exactly what they need to do to go from wherever they are to wherever they want to be. So if you're interested in my services, you can reach out to me on Instagram. It's probably the best way. It's Dr. Blade, MD, DOCTA, Blade, MD. Or you can go to drblade.com and you can sign up for a consultation.
I think I'll do
Awesome, man.
Very cool. Well, thank you, Dr. Blade. That's been a tremendous presentation. I think we had some high-level Regenix folks stop by here just a moment ago, so you had a pretty good audience.
Like, oh, we stole our PowerPoint.
I know, right?
No, seriously, Dr. Blade, that was a fantastic conversation, man. And, you really brought in a lot of evidence with a lot of practicality that I'm sure a lot of people that we all know, and just I'm sure many people in the room have dealt with. So thank you so much for that.
My pleasure. Never thought I'd be in this position with all these injuries, but this is the path I was given to hopefully help educate and inspire other people.
That's awesome.
There you go. And so everybody who's still here, thanks for joining. Again, we are InVirtuo. We are a virtual reality medical education platform, but more so a community for those of us to get together and learn, share our knowledge, share our experience. Feel free to click on the little heart on the right side of your screen and give us a like. Follow us on Instagram, InVirtuo. We're on Twitter, LinkedIn, TikTok, all that fun stuff. So thanks again, everybody. Have a good night.
All right, everybody.